This is Healthcare Today with your host, Kelly Roberts.
Welcome to Healthcare Today. Today we are on location here at PHOEBE Cancer Center. My first guest is Dr. Adam Jones. Welcome.
Thanks for having me.
Thank you. Now, Dr. Jones, you are a radiation oncologist here at PHOEBE?
That's right. I joined Dr. Mendenhall and McAfee about 4 years ago, and we have the pleasure of seeing most cancer patients that come through here and taking part in decision-making for their cancer plan.
Okay, and so tell me a little bit about your role. Your specialty is the radiation therapy?
That's right. So we specifically deliver radiation. We determine who needs it, how much, when to give it, how that affects the overall treatment plan. We often see patients who don't need radiation as well, and simply sometimes that's just for an opinion so that we can help other doctors make decisions.
And while we're talking about that, one thing y'all have here making decisions is y'all still offer the multidisciplinary tumor conference?
Yeah, absolutely. We actually do 3 of those in a given week, the largest of which is going on typically noontime on Thursdays. We discuss really any cancer that any physician feels is important to bring to the table. It's an opportunity for approximately 15 or 20 different types of physicians, pathologists, radiologists, radiation oncologists, surgeons, medical oncologists, pulmonologists, all come to the table and discuss cases. We debate what the best treatment option may be, often reflecting on national guidelines and how that applies to that specific patient. We also have a pulmonary-specific conference on Wednesday morning. It's called Chest Conference. Our thoracic surgeons are there, led by the pulmonology team, and we also have a breast conference. Same thing on Thursday morning. So it's an opportunity to discuss patients in a large group of different physicians to make sure that we're not forgetting anything or leaving something on the table. No cancer is routine. Not anyone's cancer is the same. So what I'll often do, if I have any questions about a treatment plan, I'll tell the patient, hey, this is what I'm thinking. I'd like you to come back, say, on Thursday, while at Thursday at noon I'll be discussing your case with many other physicians. That way we solidify the treatment plan, and it gives us confidence going forward that we're doing the right thing.
Great. What a great benefit to patients. Now, talking about radiation, there's different levels, different doses. Does that go along with the different types of cancer?
Yes, absolutely. Sometimes radiation is used by itself with curative intent. That's called definitive radiation. Sometimes it's used as an adjunct. It can be given before or after surgery, and sometimes it's given concurrently with chemotherapy.
Okay, and that also helps the patient. Now, it's not just about the treatment. You're here with them through the entire journey. So talk to me a little bit about that, because I'm sure it's very scary for patients to first sit down and find out they need radiation.
Absolutely. That first day is a bit of a shock. We review all the important points about the cancer, the stage, the treatment intent, and at that point we're also reviewing imaging, trying to consider what's going to be the fallout from treatment, what are the side effects going to be, what are our expectations. And then as they come back for planning or marking, and then there's always some computer work, I say, going on in the background. That's my opportunity to fine-tune the plan on computer. And then from starting and then going forth, I see patients at least once a week during their treatment course, or more often as needed. We have a large treatment team here in the radiation oncology department. We have therapists, we have physics team, we have nurses, we have ladies up front, we have who help get the patients where they need to be, who answer phone calls. We have ladies in the back who make sure that folks get where they're supposed to go. So it's not just the physician taking care of the patient. We have a large team of about 40 or 50 down where we work.
Great, and I think I read you even have nutritionists that help them try to stay, on the right path of what they need to be doing.
Yes, ours is named Jan, and the last time I called her a nutritionist, she corrected me and said, no, my dietitian. But it's very important, specifically with head and neck cancer patients, patients who have lung cancer. The nutrition piece becomes critical, and she will see those patients routinely during treatment. She and I are constantly negotiating things such as calorie count. Does the patient need supplemental feeding? Do they need to be hospitalized for a nutrition need? That's critical in cancer care as well.
So we wanted to speak a little bit about uterine and cervical cancer today.
Right. Just to speak about them differently, and they're actually completely different types of cancers, although those organs are connected in the female reproductive tract. Cervix cancer, which we're seeing less of these days, and that's a good thing. It has to do with pap smears and HPV vaccination. Cervix cancer is typically treated with surgery if it's very early, but most cervix cancers, however, don't present that way, and radiation is the backbone of treatment. In fact, we cure cervix cancers with radiation, in most instances combined with chemotherapy. Uterine cancer, however, is usually approached from a surgical option up front, where the uterus, the cervix, lymph nodes are removed, and then sometimes there's a need for radiation or chemo behind the surgery. So in those instances, radiation is used as an adjunct. Specifically with cervix and uterine cancer, we're able to use something called brachytherapy, which is actually a very old name, a very old an idea in radiation therapy, but it simply means placing a sealed source or radioactive source very close to or within the tumor. So in cervix cancer, we're able to place a device inside the patient, and this is kind of after the external beam portion, and it boosts the dose to a higher dose, and this increases our chances for cure and decreases side effects. And a benefit that we have now that we did not have years ago is that we can do this as an outpatient, specifically with some new technology called HDR, or high dose rate brachytherapy. Patients are able to do this as an outpatient, as opposed to being placed in the hospital for 2 or 3 days at a time.
That's great. Now, you mentioned you're seeing less cases, you think, for preventative and things. That's great. Let's talk about some of those preventative measures you'd like to see patients take.
Right. So for cervix cancer, it's pretty easy, and our gynecologists around town are very aggressive about Pap smears. I do know that the guidelines change periodically, and it's a bit hard to follow for me, but generally speaking, most sexually active patients will need a Pap smear every 1 to 2 years, depending on what that shows or whether there's presence of something called HPV virus. That may change their follow-up somewhat. There's also now a well-recognized HPV vaccination, which is used in younger ladies and now young men, which prevents cancer. And we're already seeing nationally a trend of decline in number of cervix cancers specifically because of that.
Okay. And I'm going to jump to another type. Prostate cancer is something y'all treat aggressively here and have great success with. Let's talk about that.
So prostate cancer is one of my favorite topics to discuss. And I always say with my patients, men, we are not the best communicators. So women do tend to talk about breast cancer and get that awareness out there a little more. But prostate cancer is also not a small problem. In fact, there's been some recent misunderstanding about the role of PSA. We heavily rely on our primary care physicians to have that conversation with men about, is PSA, that's a blood test, is PSA screening important for men or not? And what we have seen is that over the past 5 years, there was a national push not to do it. Well, at least clinically and anecdotally, we've seen a rash of higher grade cancers coming through, and people are also seeing that trend nationally. In terms of treatment, if you can treat a cancer earlier, then it is always more curative. That is standard across the board. Both radiation therapy and surgery are used to cure prostate cancer. We offer the non-surgical arm, and we feel very confident about what we deliver. In patients who are appropriate, we do try to do the brachytherapy boost as well, and that's where we actually place seeds, radioactive seeds, into the prostate gland. We join with our local urologist to help achieve that. That's a procedure that we do together, and that often, again, increases cure rates and reduces side effects.
So you're doing a lot of great things here, right here in Southwest Georgia, and we appreciate you sitting down and talking with us today. Stay tuned, and we'll be right back.
I'm Patsy Martin from Albany, Georgia. In 2012, I was diagnosed with breast cancer. I was traumatized. Cancer was not in my family, so I was much in denial that this couldn't be me. I was introduced early on to the Cancer Center. I had never seen such a group of compassionate folks who really cared about choosing the best treatment plan for you. My family was most impressed, and of course thankful that we were going to be able to get treatment here in Albany. The credentials of the team here, of the center, there's no reason to go anywhere but here. We have the best breast cancer treatment center in the state as far as I'm concerned. Why travel when you've got the very best here?
Welcome back. I'm here on location at PHOEBE Cancer Center. I'm now joined with Dr. Ramon Cafiero. Welcome.
Hi.
Thank you for being here today. And you are a urologist here at PHOEBE.
Correct.
Is that correct? Tell me a little bit about your role here at PHOEBE.
Basically, it's take care of male and female, avoiding dysfunction. Okay. And that's our main goal, but we also take care of cancers of the kidneys, the bladder, the prostate in men, and testicle in men also. And we also take care of children.
Tell me a little bit about, I know men are sometimes they're at a higher risk for prostate cancer, but let's talk about their risk factors.
Risk factors for men, the number one risk factor is if you're African American. Okay, you have an increased risk of prostate cancer, and instead of screening above age 50, we recommend age 35. Also, if you have a family history of prostate cancer, like especially a father, an uncle, a son, a brother, a direct relative, we recommend screening.
Okay, and you typically screen by a blood test, is that correct?
Yes, it's a blood test. It's the PSA, or prostate-specific antigen, which has undergone some scrutiny in the literature because it's not as great as we thought it was, but it's still the best test we have, and I still encourage it, that and the rectal examination. Those two together will pick up cancers. If anything, we can pick up a baseline, so we can then tell if there's been a change.
Okay, so the baseline is like a level at where that antigen is.
Right.
And then you'll kind of compare it as you watch it on annual visits?
Yes.
Okay, and then you talked about the other exam, the rectal exam. That helps you feel masses, things
Yes.
like that?
Some prostate cancers are so undifferentiated or ugly looking, they forgot they were prostate cancers. They're so aggressive, and they forgot how to make PSA. And those we can pick up with a rectal exam. They're usually very aggressive, hard rock nodules that we can easily feel. So the rectal, unfortunately, we still have to do the rectal exam.
And then for women also, let's don't exclude them. They are at risk as well?
For bladder cancer.
Bladder cancer. Let's talk about that.
Bladder cancer can happen in men and women. The biggest risk factor is smoking.
Okay.
Basically, you don't see bladder cancer in many non-smokers. If you smoke, your risk goes up. It doesn't mean that you're going to get bladder cancer, but if you take all patients with bladder cancer, 95% smoke. The other ones have some untold risk factors, maybe secondary smoke, secondhand smoke.
Okay. And so what else should be screened as far as overall urology health for women? They suffer sometimes from overactive bladder?
An overactive bladder is essentially urinating more than 8 times a day, and that includes not waking up at night maybe once or twice, and even then, I consider that abnormal for some people, but if you go more than 8 to 10 times a day, you should be seeing your physician. There's certain things that can cause that, just an overactive bladder, but you can also have occult cancer. Bladder cancer can present with blood in the urine. Either the doctor picks it up, so that's also part of our screening. We check the urine for an analysis to see if there's any red cells. But certainly, if you have frequency and urgency, there's a type of bladder cancer that can present like that, and the only way to diagnose it is by looking inside the bladder. So that's very important too.
Okay. And then kidney stones. You see those commonly?
Very common. We're kind of part in the stone belt, where in the southeast you have a lot of dehydration, maybe something in the water, but we see a lot of stones. And stones are, both men and women are at risk. Dehydration is a number one risk factor, not drinking enough water. Family history does play a role there too. If your parents or siblings have kidney stones, you are a higher likelihood of having kidney stones.
And then let's talk about some of the treatment. You do some other procedures, urological procedures and surgeries. Let's talk a little bit about those. What type of surgeries do you perform?
Well, pretty much anything for the male and female urinary tract and the male genital tract. So we remove cancers laparoscopically, like of the kidney or the prostate. We do endoscopic treatment of cancers, like scraping bladder cancers. We remove stones at PHOEBE. We have every single treatment modality for stones, which is shockwave modality with electrical energy, ultrasound energy, or laser energy. And so it depends on where the stone is and how big it is. We can take it out through your back through a small incision instead of making an open incision like the old days. Or we can put a scope inside the urethra, then the bladder, and then we can go all the way up to the kidney with these small scopes and take the stones out that way. We do surgeries for children, like if they have hypospadias, the little pee hole is not at the tip, it's a little bit more proximal. We also do surgeries for testicular cancer, removing the testicles if there's such a thing. Men who can't urinate, we have a green light laser or a TURP where we resect scrape the prostate open. We have that available. Pretty much we have a lot of procedures. Some specialties have 1 or 2 procedures that they do, like the gastroenterologist. In urology, there's hundreds of procedures that we do.
Right, and you work with a collaborated effort with, we had Dr. Jones on earlier, one of the radiation oncologists.
Right.
And I'm sure you work with area primary doctors in town and gynecologists, because often they need to see a specialist to treat.
When you have a diagnosis of prostate cancer, patients need to understand that unlike testicular cancer, which grows really fast, we were able to find a cure in the 70s. because people would not do well. You knew within a year. So you try something different in a year, didn't work, try something different. With prostate cancer, we do something different. It takes 10 to 20 years. And there's many ways to treat the prostate, radiation or surgery. There's advantages and disadvantages to both, and that's why I believe that every patient with prostate cancer needs to know and have informed consent to talk to both the radiation oncologist, the oncologist, and the urologist to see what's available. Sometimes it may not even be treatment. Sometimes it might be observation, where we follow the PSA. The cancer is so small, we think it's not going to affect her life. We may rebiopsy the prostate in a year, and that's where we have to collaborate. They provide a great service here, the radiation oncologists and the ultrasonographers, where we can do template biopsies. If we have a negative office biopsy, but we're still worried, we can go ahead and do a biopsy in the operating room with a ultrasound personnel, and that also helps us pick up more cancers.
Okay, and then we talked a little bit about having the multidisciplinary tumor conference board where y'all all can get in there and talk about cases.
Right.
And that's helpful for you with patients?
Yes.
Talk to me a little bit about that, and what's the benefit to patients?
The benefit is that they get a multidisciplinary approach to their treatment, especially when you have a strep throat, there's penicillin. Everybody agrees on that. However, when you have certain cancers, there's many ways to treat it. So it's best if you hear the opinions of the different specialists, because, you know, sometimes you butt heads. You might think surgery's better, they might think radiation's better, and then you kind of have to talk to the patient that we have an even divided thing, and then a lot of times they ask me what I would do, okay, and then I have to go in and say, well, I haven't had it done, but if I would have it done, this might be due, or tell them that it's okay if you pick. It kind of makes the patient feel more comfortable that they're getting multiple opinions. It's like having multiple doctors looking at their case, not just one.
Right, and that is a great benefit, and everything's going to be different for every patient.
It individualizes care to that patient.
So I appreciate your time, and we're glad you're here treating both male and female patients at PHOEBE Urology. We're going to take a quick break. Stay tuned, and we'll be right back.
Hello, my name is Bill Hardegree. I'm a Lee County resident. I was diagnosed in November, prostate cancer. My doctor recommended PHOEBE for their care. I was scared. They took me in and said, hey, it's going to be all right. The whole unit ran like a well-oiled machine. They have the latest equipment, a well-trained staff, and it's just like dealing with family. I'm grateful PHOEBE was there, so I would have hated to be up in some other city where I didn't have my friends. I was so fortunate. Every day is a new day.
Welcome back, and once again, I'm here on location at PHOEBE Cancer Center. I'm now joined with a patient, Judge Bob Revell. I want to talk to you a little bit about the care that you've been receiving here at PHOEBE Cancer Center. Tell me a little bit about your journey.
Well, the first meeting I had was with Dr. Chuck Mendenhall. When I learned that I had prostate cancer, one of the first things obviously is to determine what your treatment options are, one of which was to come to PHOEBE and undergo radiation oncology. Dr. Mendenhall's office called and made sure that I came in right away, so I didn't have to wait over the weekend to learn about my options, avoid that anxiety. But I met with Dr. Mendenhall. We discussed my treatment options, went home and thought about it, consulted with my other physicians, and then ultimately underwent a treatment plan here at PHOEBE.
Okay, and how did that, when you met with Dr. Mendenhall, he felt like you laid out all your treatment options, you felt comfortable about the things he talked to you about?
Absolutely. Dr. Mendenhall and I had actually known each other over the years, and he took the time with my wife present to explain each and every option and to go into detail, to answer any questions, not do so in a hurried manner, and I really felt like when I left the meeting with him that I had the information I needed to make a decision about that aspect of treatment. Now, from that point forward, I became part of the PHOEBE family in the sense that I would go to his office. The first people I would meet would be the receptionists, the ladies in the office, who would greet me. I eventually underwent the procedures necessary to come up with a treatment plan. 25 radiation treatments here at the hospital. Ultimately had brachytherapy surgery to implant the seeds. And in that journey, obviously, I came into contact with many employees. PHOEBE wasn't a hospital anymore. It was a group of professional people that were caring for me. And the one thing that has stuck out in my mind is, of all of those people that I've come into contact with, I have never come into contact with anyone that wasn't positive or upbeat, and it was all about me. Nobody, if they were having a bad day or had problems of their own, I didn't know about it. And that's been very uplifting, it's been very comforting, and it's one of the things that have made the treatment plan go so smoothly.
We're very fortunate to have this type of care here in our own community. How important was it to you to be able to stay here with loved ones, Judge Revell?
Well, I think it's incredible that I am receiving the type of care that I am, and it's a 10-minute drive for me to come from River Point out near Cheehaw to the hospital, park and walk into the hospital and have world-class treatment. Obviously, to be so close to home, to have the comforts of home, to have my family be nearby has made it much easier.
And you look like you're feeling great. You're back to doing the daily activities you enjoy doing?
Well, I have been very fortunate, and the side effects of the treatment have been minimal in my case, and I have been able to enjoy life just as I have all along, with a minimum of discomfort.
Okay, would definitely refer anyone going through this to at least come see their options here at PHOEBE Cancer Center.
Well, it's been my experience, and I've checked a lot of things out, that we have world care cancer treatment right here, and in the radiation oncology department with Dr. Mendenhall, Dr. Jones, and Dr. McAfee, three of the most capable and caring physicians that you could come into contact with. So we are amazingly fortunate that right here on 3rd Avenue in Jefferson in Albany, Georgia, you can receive that type of treatment.
Right. Well, I'm so glad you were able to receive that care and that you're doing well. We appreciate your time sitting down talking with us today, Judge Revell. Stay tuned and we'll be right back.
I'm Sarah Phillips, and I'm from Albany, Georgia. I had regular mammograms, and one showed something questionable, and they wanted me to come back in 6 months. And when I did, it showed something questionable on both sides. It indeed was malignant. It was really a shock. They thought the best thing to do was to go ahead and do the surgery and remove both breasts. We did that, and then Dr. Earhart came in and did reconstruction about 3 or 4 months later. That's been almost 10 years. My father had cancer back when I was a newlywed, and my mother had to drive him back and forth to Atlanta for treatments. We had nothing here. And the fact that we can stay here and get everything we need is so convenient, because you can go to your doctor's appointment and go home. I would recommend PHOEBE to anyone because they have everything you need. I have complete trust in the doctors. Compassionate, accessible care, quality care. I really think it's top-notch.
Welcome back, and once again, I'm here on location at PHOEBE Cancer Center. I'm now joined with surgical oncologist, Dr. Sanjay Lena. Thank you for being here today.
Thank you, Kelly, for having me today.
Now, you are a surgical oncologist here at PHOEBE. Tell me a little bit about that role.
Okay, so I'm a fellowship-trained surgical oncologist. Finished about 4.5 years ago. I've been at PHOEBE 4.5 years ago. So surgical oncologist is basically surgeon who's after general surgery does 2 or 3 years of surgical oncology training in taking care of cancers, cancer surgery, remove cancers like breast, skin cancer, stomach, colon, pancreas, liver, rectal, all these cancers.
Okay, and we've been talking about the world-class medicine and the treatment and technology they have right here at PHOEBE. I want to talk a little bit specifically about a piece of equipment called the Da Vinci Xi. Tell me a little bit about that.
So we have had Da Vinci for a few years now, but recently we got the Xi, which is the most up-to-date model that we have in Da Vinci, the robot-wise. And we are lucky that we have it right here in Southwest Georgia. So Da Vinci robot gives us access to parts of the human body, the anatomy, like the deep in the pelvis, up here in the near the esophagus, near the diaphragm, that we can normally access. Like we can access, it's like literally painful when you do open surgery. When you're deep down in the pelvis, it's so painful. It takes long time consuming, hard on the patients with long incisions, everything. Well, Da Vinci solves all that problem with small incisions. We can do this surgery much easily, and also like we can use the staplers, and we can also, there is a special capability on the Da Vinci where you can identify the ureters, make sure they're not cut or injured, make sure the gallbladder duct is safe, not injured. So we have all those extra capabilities on X-ray, and we are lucky to have that here.
Okay, so it sounds like it's just very precise. There's not guessing, but you know exactly where you are.
I have had few patients when I said I'll be doing the robotic surgery, they were like, oh no, I don't want a robot operating on me. So then I told them all it does is whatever I tell you to do, because whatever movements I make with my hand, that's exactly movements it makes. It's precise, okay, very, very precise.
I think a lot of people don't realize the benefits, because am I correct? It's sometimes less downtime?
It's pain-wise, length of stay-wise, recovery-wise.
Just a much better option. Yeah, okay, and I want to talk a little bit about some specific procedures that you do. So you actually say women that have a lot of reproductive cancer issues. Talk to me a little bit about what you do.
So what we do is, if patient has a uterine cancer, the gynecologist goes in first and does the radical hysterectomy, taking the uterus out, cervix out, up until the upper part of the vagina, and then the tissue around the uterus. And then after they are done, I go in robotically, again all this through like 4 small tiny incisions, go in and take out the lymph nodes, which is for staging, to see what stage the uterine cancer is, if it has spread to lymph nodes or not. So I take out lymph nodes around the major blood vessels in the pelvis and around the aorta in the lower abdomen. This, if does open, patients need a huge incision from all the way to the pubic bone, all the way up above the umbilicus. But here all we do is through real tiny incisions, maybe a centimeter big, 4 incisions, that's all.
And
no other
that's
scar.
fantastic, because so then you have the option when you're taking that lymph node, then they're getting a collaborated care, because now you're giving them the opinion you know for sure with the pathology, and you're retrieving that in one surgery.
Right, that's right. But now patients, I have seen patients go home day after, or within 2 days, most of the patients go home after robotic surgery like this.
And so the Da Vinci is universal, so you mentioned that, but so there's multiple surgeries you can use it for. Just really want people to be aware of in this community how lucky we are to have this piece of technology, and that this hospital has invested this so that you can perform surgeries every day.
Exactly, so not many patients know that. I'm thankful for doing this, so that patients know that there is this option available here, right here at PHOEBE.
Right, and they don't need to be fearful that it's a robotic surgery. That's right. That's a big take-home message. Just very thankful that we have it here. Exactly. Right, well, we appreciate your time and definitely welcome you, and so glad we have you here in our medical community.
Thanks a lot, Kelly.
Okay. If you'd like more information on what PHOEBE has to offer with the PHOEBE Cancer Center, please log on to PHOEBecancer.com, and we'll see you next time here on Healthcare Today.